Hi friends, good evening. I'm Dr. Ashutosh Gupta, and today let us talk about uterine arteries. Okay, so the first sort of a window of opportunity in which we really look around for the baby is level one, which is at something around 12 weeks and 5 days, right? And then probably I do have a lot of videos in which we have told that for all practical purposes we can really do the level two, right? So there is hardly anything which is being left out as far as the baby is concerned, right? Okay, so we are inverting the pyramid, and then probably at 12 weeks and 4, 5, 6 days, we can really look around for the baby in complete toto, right? But while on the other hand, we can see a lot of things across to the fetus, there are something that are being missed. So the things which are being missed are the uterine arteries. Uterine arteries meaning thereby the flow that is being showed up to the uterus, that is from the right and the left uterine arteries, right? And many a times we've identified that the resistance of the uterine arteries is not that great at 12 weeks, right? So meaning thereby that there is always a situation of a demand and supply. So meaning thereby when the demand increases as the baby grows from first trimester to second trimester, or meaning thereby that from 12 weeks to something around 16 weeks, and then therefore the demand increases, therefore the supply increases, meaning thereby that once we've identified that the uterine arteries are abnormal at 12 weeks, okay, so which is very very pertinent and important so as to identify and highlight that probably we're dealing with something, the abnormal uterine artery. So we do have established sort of a waveform. We do have established nomograms. So we do have a resistance index or the pulsatility index, which is called as an RI or PI. So we do have those established nomograms for the uterine arteries whenever we are seeing the baby, whether we are seeing at 12 weeks or whether we are seeing at 16 weeks. But in majority of the cases, in 90% of the cases, what happens is this: as the demand increases, the supply from the uterine arteries also increases, right? So we have to establish. So if it is fine from the 12 weeks itself, then we are happy about it, and then that lady becomes a low risk. But many times it doesn't happen, right? So meaning thereby that at 12 weeks we identify that the uterine arteries are higher. So meaning thereby that it is very very important and pertinent. So follow it out across at 16 weeks, and so as to ascertain what is happening to the uterine arteries. Right, in 90% of the cases, it usually behaves well, and then it falls, and the resistance falls. What if it doesn't falls? So probably there are few cases that probably we can talk about. So this is the lady that we are seeing at 12 weeks. So we can identify that this is the uterine artery. So we do have the RI and PI values of both the right and the left uterine arteries, right? And then the same lady is being followed at sometime 15 weeks. So we identify that there is a post-diastolic notching in both the uterine arteries, and then the resistance index, they have not changed much, right? This is the second case that we are seeing at 24 weeks and 6 days. And then we identify that the post-diastolic notching is there in both the uterine arteries, right? Whether it is the right or the left. And then probably if we identify that this is the notching is here, and then the values and the nomograms and the flow is not that great. So how does it reflect into a high umbilical artery resistance? Okay. Still, this science and the technology and the ultrasound techniques they've advanced really to the great extent, and the NICU techniques, NICU techniques they've advanced really to a great extent that we can salvage the pregnancy, and then we can save the babies of something around 700 and 800 grams. Okay, but the very very important point is this, that we should not miss on the uterine arteries. Pehla. दूसरा, if the uterine arteries are abnormal, then probably they need to be followed out across 16 weeks. So, meaning thereby that at 16 weeks we identify that the RI should fall less than zero point 0.6 and the PI should fall less than zero point 0.9. If it is beyond than that, then it is abnormal. Meaning thereby that probably we need to also identify that the post-diastolic notching is there. So that lady becomes in high risk to land up with a PIH and preeclampsia. So PIH is a pregnancy-induced hypertension. So this is the effect. It is not the cause. Cause is this, that the uterine arteries are not getting remodeled during the pregnancy. What they ideally should have had then, meaning thereby that the diameter or the flow from the uterine artery should improve to the umbilical arteries. Now what happens is this, that the umbilical artery in the last case, the SG ratio was 5. So which is, so meaning thereby that the flow to the fetus becomes very precarious. So in that case, what happens is this, that the fetus says mayday, 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 and asks for the help to the mother. And the pretext of helping the fetus out, what happens is that the mother increases the blood pressure. अपना ब्लड प्रेशर बढ़ा देती है मदर इस प्रिटेक्स्ट में कि that lot of blood would reach to the baby. Okay, so we need quantum of blood getting to the baby, not the pressure. So once the pressure increases, mother gets into an hypertensive sort of a disorder. She might start losing some protein through the urine, and therefore she ends up in a preeclampsia. And then usually that happens about 26, 28 weeks. So the baby is also not growing, and then the baby is very premature. So it is a low birth weight and prematurity. At all these things happening at 28 weeks. So meaning thereby the salvaging the pregnancy becomes very, very difficult. So highlighting these cases at 12 weeks and then following them across by 16 weeks. If it is not following, if it is the uterine arteries are not getting remodeled, it is very, very pertinent that probably we should start with the low molecular heparin. Now we do have a lot of nomograms available, doses भी उनकी बहुत अच्छे से established है, सब कुछ बहुत अच्छे से established है, but the thing is this that the Clexane is a low molecular heparin. It has got a half life of 12 hours. So meaning thereby that whenever we sort of decide to start with low molecular heparin, it has to always being given in two doses, meaning there are morning evening, right? Okay, so we can start with some doses which is usually 0.1 milligram per kg per day into two divided doses. So this is the doses that probably we can do about it. So heparin has been identified to have a lot of beneficial effects to the fetus. Whatever the uterine arteries are there, it doesn't allow them to clot. It helps further and new blood vessels to get formed. Third, it has also got some immunological and immunomodulation effects. So meaning thereby that it also helps the mother's sort of an immunological response to the pregnancy. So meaning thereby that if we are from 28 weeks, if somehow we are able to get into 30 to 33 weeks or so, or 34 weeks, so from to something around 1200 grams, what we can reach up to is 1.8 kgs. Right, a 28 weeker baby would definitely need a NICU. At 34 weeks baby, it would be take home baby. Right. So in nutshell, it is very, very important so as to identify the uterine arteries at 12 weeks. Then we follow them at 16. If they are not following the standardized norm RI and PI norms, so it is all better that probably we start with the low molecular heparin, and then we titrate the doses of the low molecular heparin according to the gestational age and then the umbilical arteries and the uterine arteries flows. So then our target is to reach up to 36, 38 weeks. If it is not there, meaning thereby that we really don't know when this PIH or the dreaded preeclampsia is going to set in into the mother. So probably if we are able to reach up to 34 weeks, which is something around 1.8 or 2 kgs, which is a lower band of being a low of the fetal weight, then also it becomes a sort of a take-home baby, right? So meaning thereby that all these things, in my own experience, of something around 20 years, but this Lomec heparin has worked wonderfully well, and then we can manage these pregnancies of these uteroplacental insufficiencies, and we can really take them to sort of a preterm or term at 34 weeks or 36 weeks, and therefore it becomes a take home baby, right? Thank you very much for your patience.